Okay, so we now switch a little bit gear and we'll talk about clinical feature and diagnosis. Well, diagnosis is very simple. Diabetes, high blood glucose level. So these are the American Diabetes Association criteria for the diagnosis of diabetes. Fasting glucose level that are elevated. 2-hour post-oral glucose tolerance test, although we almost never do an oral glucose tolerance test in clinical care. Hemoglobin A1C of more than 6.5, 48 millimoles, or in patient with classic symptom of hyperglycemia, a random glucose above 200 or above 11.1 millimoles. So that are the criteria for diabetes. And so this is looking at different glucose tolerance categories. This is the diabetes on the top with the fasting glucose or the 2-hour postprandial glucose. Normal individual have a glucose fasting that is less than 100 or less than 0.5, 0.6 millimole, and 2-hour post glucose of less than 140 or less than 0.7, 0.8. But then the green zone in between are the patient with impaired glucose tolerance called pre-diabetes, and those are patients that are at high risk of developing type 2 diabetes. We all know that diabetes is common as it goes as age increase. So these are prevalence of people with diabetes. There is really no difference between gender, male and female. They have the same relative risk of diabetes. But of course, the prevalence of diabetes is much lower in a lower age group, and it goes up with aging. And in the US, there are also, when we look at our ethnic composition, non-Hispanic whites have a much lower risk of developing type 2 diabetes, although they have a much higher risk of developing type 1 diabetes. The patients that are Hispanics or non-Hispanic blacks, and the ethnic group that has the highest incidence of diabetes in the US are the American Indian. As I mentioned before, type 2 diabetes is a progressive disease. This is a simple graph. I mean, as time goes by, irrespective of what happened in terms of treatment, patient treated with diet, the black line, or metformin or sulfonylureas, as year goes by, the pancreas slows down and there is a decreased loss of beta cell function. And of course, the clinical complication of diabetes are what is the most important characteristics: retinopathy, nephropathy, and neuropathy, the diabetes specific, and the increased risk of macrovascular disease. So retinopathy diabetes is still the most common cause of blindness in adults. In elderly is macular degeneration. And in the US and Europe, diabetic retinopathy is about 15 to 17% of blindness, with a lot of people losing sight because of diabetes. And over 20 years of diabetes, about 60% of patients with type 2 diabetes develop some retinopathy. In most patients, the retinopathy is just this background retinopathy, it's just a fundi with some dot hemorrhages. But you can have more severe form of proliferative retinopathy, and this is a patient with a major vitreal hemorrhage, and so these are the vision-threatening lesion of retinopathy. Diabetic nephropathy is also common, and right now we have diabetes is the cause #1 for end-stage renal disease, and these are data from 2014, but in the US, 52,000 patients develop end-stage renal disease and had to go on dialysis or getting a transplant because of diabetes. And especially African American in the US have a much higher rate of nephropathy and kidney disease. And of course, having kidney disease increases the chance of having heart or disease or stroke. Diabetic neuropathy, similar to retinopathy, about 70% of people with diabetes develop some symptoms of diabetic neuropathy, and diabetic neuropathy is still causing 60% of non-traumatic limb amputation in the US. The typical lesion is an ulcer developing under the metatarsal head that can progress, and then eventually, if not healing, can lead to amputation. And then the risk of coronary artery disease. This is a coronary artery with a thrombus at the time of an acute heart attack. We know from all the epidemiological data that patients with diabetes in the blue line have more than a double risk of disease, cardiovascular death than patients without diabetes, irrespective of other cardiovascular risk factor. And when we look at the incidence of acute myocardial infarction in patients with diabetes versus patients without diabetes, these are data from Finland. the risk with having a prior MI is much higher than in the non-diabetic, is 5-fold or higher, and the patient that had a prior MI, the risk of developing another heart attack is much higher. And so we know that most patients with diabetes, 55% of them die of heart disease, another 10% of cerebrovascular disease. So large vessel disease is responsible for a large percentage of that.